What I'm going to do is present the experience from the Transverse Myelitis Center at Hopkins, which we've put together into a study format. We've had a lot of discussions about what these diseases are, what are the differences. Let's start shifting and say, all right, well, what do we do to get people better when they're afflicted with one of these illnesses? So when we're talking about all of these diseases, whether it's transverse myelitis, neuromyelitis optica, there are different stages of the disorder. There's acute inflammation, which we've spent a lot of time talking about. Doug showed you those slides of spinal cords with cells infiltrating the spinal cord. But after the acute inflammation, which is going to be shown here, you have a neuron with myelin and these cells that just start coming in and causing this acute problem. You can go on after acute inflammation to have, if I can get to it, cytokines that potentiate both the inflammation and ongoing damage. This damage, the chronic degeneration, can happen even after the cells are gone, even after the inflammation has left. And down the road, they can cause just as much, if not more, damage. But the good news is there's endogenous repair. Your body remyelinates demyelinated neurons. It's never as good as the original. So back to that stereo analogy, if the cat has chewed on the wires and demyelinated the wire, if I come back in and I take electrical tape and I just shore up where the cat was chewing, I improve the signal efficiency. It's never as good as the original. Your body does the same thing. It remyelinates, but never as good as the original. So all of these areas, whether it's the trigger of the disease, the acute inflammation, the chronic degeneration, or the endogenous repair, are all areas where we can intervene to improve outcomes. So what are the interventions? Well, if we knew the triggers of these diseases, if we knew the causes, we could just avoid them or vaccinate against them or do something to prevent it from even happening in the first place. During the acute inflammation, we're going to talk about two possible interventions. One is, what do we do to get rid of the inflammation? And something called neuroprotection. Can I put a force field around your speaker wires such that they survive the attack? And when the inflammation leaves, you're left with little damage. For the chronic degeneration stage, you could talk about neuroprotection or preventing recurrence. And endogenous repair, we could either promote the natural system or iatrogenically, meaning we could intervene and try and promote repair. But for today, we're going to talk about acute therapy. What are the goals? What are the mechanisms of the drugs? And what have we learned from transverse myelitis? All of the acute therapies I'm going to talk about today are meant to limit inflammation. If somebody comes to me in the throes of an acute attack or an acute exacerbation of transverse myelitis, what can I do to limit the amount of damage they're going to have? So there's a national campaign going on for stroke. So people for years knew the symptoms of a heart attack and knew to get to the hospital. They'd have chest pain, shortness of breath, they'd be sweating, they'd feel sick, and they'd go to the hospital mainly because it hurt was the primary reason. Strokes tend to be painless, and what we found over decades was there was not an impetus for people to go to the hospital when their arm was dangling by their side and couldn't be moved. They kept saying, it'll get better, it'll get better. And a day would go by, and it didn't get better, and then they'd come to the hospital. There was not a push in terms of a public awareness campaign to get people to the hospital faster until we had a treatment that could be used for stroke. So after the initiation of what are called thrombolytics, these clot-busting drugs that have to be used within a certain number of hours from symptom onset, we realized we had to educate the population, educate everybody, doctors, nurses, patients, everybody, about the signs and symptoms of stroke, because we had to get you from your house with that dangling arm into the emergency room and be given a medication in under 3 hours. Nothing happens in under 3 hours in an emergency room. And so if you sit at home for 30 minutes with that dangling arm, you've just lost 30 minutes of potential time of treatment. So they came up with a public health campaign about brain attacks, just like a heart attack, to get people in faster. So what we're going to start talking about are what are the acute interventions that we can do for transverse myelitis. So the goals are to limit inflammation, limit the substances that lead to nervous system damage, and what can we do to protect the components of the nervous system. There are a variety of drugs, and I'm going to give you a brief overview of what their mechanisms of actions are. We're not going to go into too much detail, but I want you to see some differences between the approaches. So first, steroids. I'm not going to ask, but probably 99% of people in this room have either received, know somebody who has received, or prescribed steroids for one of these events. The idea of steroids is to dampen down the inflammatory cytokine cascade, these proteins that these cells are secreting, inhibit the activation of certain parts of the immune system, decrease the number of those cells, the number of cats that are getting into the study, keep them out into the blood system and not causing damage, and try and kill off. This is kind of, the SPCA would get me in trouble for this, but this is taking the cats and just shooting them, trying to make sure that they're just not going to get in. IVIG, or intravenous immunoglobulin, this is a product that is pooled from donors. So each bottle of IVIG, which are antibodies, just collected antibodies, comes from about 2,000 donors, blood donors. And we take out IG, immunoglobulins, from each of those donors, and we pull it together, and then we give it back to patients. And we think giving this big, massive bolus of antibodies helps to suppress the immune system in a variety of ways, none of which have been conclusively proven, but we have evidence for each. One is to try and just neutralize any bad antibodies that are circulating in you. Another possibility is to act as a feedback loop on your cells that are producing the bad actors, producing the antibodies. And if we flood your system with a massive amount of antibody, maybe we tell them that we got enough, shut down, stop making the bad ones. And then there's a variety of other possibilities. But the idea here is to shut down or suppress mainly the humoral side, the antibody-producing side of your immune system. Now, when we compare this to something called plasma exchange, or PLEX, or plasmapheresis, all of these terms are used interchangeably, this is the idea of taking out circulating antibodies, as well as other proteins, from your blood in something that's akin to dialysis. We place a special IV, usually in a large vein, and it's got two ports. One, your blood comes out of. It goes to a machine where we separate out the serum. And then the other port, your blood comes back into you, having been freshly cleaned, if you will. And the idea is that if you have a circulating antibody that's causing problems, we can clean your blood of that antibody by using plasma exchange. And then there's a drug that Doug talked about this morning in the setting of very high doses, cyclophosphamide. This is definitely something that's main target is to kill off these cells. If you remember that slide of the couple red cells that get activated by an antigen, and then they start reproducing and reproducing and reproducing, and now there's hundreds, thousands, millions of them, cyclophosphamide is meant to kill them off. It is not a smart bomb. It is not just going to take out the bad actors. This is much more of nuclear warfare. It's meant to take out all of the immune system, or a good portion, or put a dent in it, in the hopes that we're going to take out the bad actors preferentially. So let's talk about these therapies in the setting of transverse myelitis. So why haven't we had large-scale trials to decide what's the best therapy? What should emergency room physicians, internists, neurologists do when they're faced with somebody having acute inflammation in their spinal cord? So it's very difficult to design prospective blinded trials, and I know sometimes it's hard to accept the idea of blinded trials because we feel every intervention we do is going to be a help. But Dr. Ford showed us great evidence where we have found in the past something very promising in an animal model, so or in a dish, the anti-TNF therapy, and then we give it to humans and they do worse. So we like to believe that we're smart enough to predict what's going to work and what's not, but we're not even close to being that smart. And so the point of a blinded trial, the point of a placebo-controlled trial, is to make sure the science is accurate and that we are not biasing the data in any way. But when you have a rare disorder with small numbers of patients presenting at any given place at any given time, it's very difficult to do this kind of trial. It's difficult to blind patients and physicians to these therapies. So for example, plasma exchange. They've done it in the past where there were people hooked up to sham plasma exchange. So they put a curtain between the patient and the machine, and you didn't know if your blood was actually being cleaned or not. And so we can do it. We can create this blinded approach as a control for a placebo effect, but again, it's very hard to do. And then there are these issues related to the heterogeneity of disorders. We've heard some great talks this morning about trying to differentiate transverse myelitis from Devic's. At first glance, it can be very, very difficult. So if you're a lumper, if you just put everybody with inflammation of the spinal cord into a trial together, what happens if after the fact you realize your therapy only worked for a subset? you now have to go back and redesign the whole trial and do it again. And so it's very difficult to get good data for this. And finally, the outcome measures are limited. What is the outcome we want? Well, it depends on what symptoms you're having. Let's say you came in with pure sensory symptoms. Your walking was fine, and I do a therapy, but I lump you in a group with somebody who is paralyzed. You're concerned about your sensory symptoms. Your walking's just fine. The person who's not moving their legs might not, care at all about sensation. They just want to walk again. So how do we measure the outcome with a heterogeneous population? So I'm going to introduce you to a couple scales that we use and give you the broad strokes so you understand the data that I'm going to present. The first is the ASIA scale, which a lot of people in here may be familiar with, the Spinal Injury Association scale. Basically, E is normal, A is a complete paralysis, it's sensory motor. It means all of those speaker wires going through the spinal cord have been affected, or the vast majority. It's the greatest level of impairment. And then B through D is in between. There's another measure that we use in terms of functioning, and that's something called the EDSS, the Expanded Disability Status Scale. So this was something originally applied to multiple sclerosis, and it actually turns out to be a pretty poor scale for multiple sclerosis because it's so heavily weighted towards walking. So in spinal cord injury, I'd actually argue it's not such a bad scale to use. It really may be a better measure of outcome in transverse myelitis than in multiple sclerosis where it was intended. But it's somewhat silly in a couple mechanisms. One is the scale itself, which is just numbers, 1 through 10, or 0 through 10, I should say. 0 being normal, 10 being dead. I would argue that if I go from a 0 to a 1, that is less important than going from 9 to 10. I could be crazy, but the absolute change becomes less of an issue than the relative change as to where you are on the scale when you start. So when we talk about a delta EDSS, which means change in your scale, what it means is if at one point you're a 7, and we do a treatment, and at the end of it, you're a 3, your change in EDSS is a 4. Now, going from a 7 to a 3, the physicians in the room who are familiar with the scale would argue, and I want you to disagree if you think I'm making this out to be more than it is, this is a phenomenal change in my mind. A 7 means you're using a wheelchair, absolutely using a wheelchair. A 3 means I can find things on exam, but you are not functionally impaired to a significant degree. You're back at work, you're doing the things you want to do. So going from a 7 to a 3 is a big, big deal. Another way to measure this in clinical trials, and this is not a validated measure, is something called percent of maximum expected improvement. So this is our fudge factor, because again, going from a 9 to 10 is a lot more significant than going from a 0 to 1. It depends on where you're starting out from. And for people who are having recurrent disease, if you have a relapse, you may come to my clinic already being a 2. Okay? So if you go from a 2 to a 6, it's different than going from a 0 to a 6. Because when I treat you, the question is, am I going to get you better than that 2? And am I going to be able to make you better than you were the week before, which is hard to do. So percent maximum improvement says if you start out here, say at a 2 or a 3, and you move up to a 7, and then you move back down after treatment, the delta EDSS from a 7 to a 4 was a 3, but it was 75% back to your baseline. Does that kind of make some sense? It's how far back to where you started do we get you? So if your baseline was a 0, that's fine. And if we get you back down to 0, that's 100% improvement. So this is the data. So in 2 weeks in the Journal of Neurology, this study will be released out of the Transverse Myelitis Center. It's a conglomeration of a lot of work from a lot of people listed here. Chitra's been instrumental in putting a lot of this together. And the point of this study was to sort out what therapies work in the acute setting, how well do they work, and are there any subsets of patients who have a preferential response to certain therapies. Now here are the caveats. Remember that whole list of things I said was difficult about doing prospective studies? Well, we're guilty of looking at that and saying, fine, we'll do retrospective. So all of this data is a retrospective analysis, which means it could be biased. Is Doug in the room? No, he's not, so I can pick on Doug. So Doug started the Transverse Myelitis Center 7 to 8 years ago. And as we learned and as we got better at what we were doing, our practices may have changed over time. And so let's say we started to self-select out patients we felt might get a better response to certain therapies. We may have biased putting people into certain groups of therapies. So retrospective is nowhere near as good as prospective, but it's going to give us a hint, I think, in terms of where we should be going with things. So let's look at the data. 122 consecutive patients in the acute stages of transverse myelitis. To date, the largest paper looking at transverse myelitis in the acute setting was somewhere between 20 and 30 patients, and it wasn't looking at all these therapies. So 122 is not a lot, but for a rare disorder, this is probably as big as they come. It's definitely as big as they come so far. So there were 4 groups of patients out of the 122. Some people just got steroids. I should mention, every group got steroids, okay? But some people got steroids and steroids.
Is this all age ranges?
This is, we'll show you the mean age, but this tends to be adults and not children. So there are some younger ones in here, but it's askew. So some people got just steroids. Some people got steroids and plasma exchange, that blood cleaning procedure. Some people got steroids and cyclophosphamide. And some people got all 3. Okay? The number of patients in each group is listed here. The majority of people got just steroids. 32, about a quarter of people, got steroids and plasma exchange. 13 got steroids and cyclophosphamide. And another 11 got a combination of all 3. The point of this chart here is to show you the similarities or differences. This is the mea culpa. This is where were the biases in terms of these patients. The ages were about the same, so we didn't just pick the young people to do plasma exchange on. We let everybody get plasma exchange. In terms of percent women, you see a big difference in this group. And keep your eye on this group all the way throughout, the steroid and cyclophosphamide. This is a biased group. And what it's going to turn out to be, I'll tell you, were people with underlying autoimmune disorders. We tended to give cyclophosphamide to routinely and not just limit them to plasma exchange. And there was a significantly higher number of women with autoimmune disorders than men. So that's where that 92% comes up. Likewise, if you had recurrent transverse myelitis, you'll see there were more of them in the later group. We got scared and we got more aggressive. We thought we had to do more to protect the spinal cord. How many people were multifocal? There's more in the last 2 groups, and it probably fits with the underlying issues about autoimmune disorders and recurrence. But when you look at the spinal fluid, and I'll show you the data on this, it's basically about the same. So it's not as if some people had more inflammation than others. It was about the same. And when you look at the percent of people who were Asia A, that means they had complete loss of function. 11% in the steroid group were Asia A, and about a third in each of the others were Asia A. So in terms of the inflammation, the only point of this slide, you don't have to worry about the numbers, is if you look at the 4 groups and compare how many white cells they had and how much protein they had in their spinal fluid, they're about the same. All of the groups overlap. So we didn't pick people with certain profiles and put them into certain treatments. Those were equally mixed. We did, however, have more people with autoimmune disorders, recurrent TM, etc., in that cyclophosphamide group. So what happened to the patients in each of these treatment groups? So the top left shows you the steroids. Okay? They had a baseline EDSS of almost nothing. Most of these people, this may have been their first attack or little to no signs before they came in. At their worst, in terms of the EDSS scale, they were above a 6. So they're teetering on, if not absolutely using, a wheelchair. Right after treatment, they go down to about a 4, with a delta EDSS just around a 2 range. When we compare that to the plasma exchange group, and remember this is steroids with plasma exchange, combination, they start off with a slightly higher EDSS. They were worse off. Their EDSS was close to an 8. All of these folks are basically needing the use of a wheelchair. And we drop them into the 5 range. When you look at the cyclophosphamide with steroids and then the all 3, you see the similar numbers. This was all comers lumped together. That is less instructive than if we can start to select out certain patient populations that had preferential responses to certain therapies, and can we find any hidden information in this data to help guide who should get which therapy. Does everybody need to get Cytoxan? Do they need to get this chemotherapy? Does everybody need to get plasma exchange? What are the choices? So we broke down the data in a little different way that makes it more user-friendly. So we separated out the patients who were ASIA A, meaning complete paralysis, no function below a certain level, wherever that level of the spinal cord lesion was, versus all else, if you were ASIA B, C, or D. We lumped everyone together. And we saw how those folks did in the different treatment groups. So first, looking at the folks who were ASIA A, in terms of delta EDSS, if you came to us and were ASIA A and just got steroids, it didn't do that much. Your change in EDSS was about 0.3. That's not worth the effort. That's not a big change at all. If, however, you got plasma exchange, you went up to 0.5. A little better, but we want to start seeing some bigger numbers, some more robust numbers. When you move to cyclophosphamide, the EDSS change in EDSS moves to a 3. And when you look at the combination group, it's 4.4. So retrospectively, with biased information in here, I have to give that caveat over and over again. This is not a prospective trial. We see within the folks who came to us who were ASIA A, there is a difference between whether or not you include Cytoxan in your regimen versus not. What about the non-ASIA A folks, people who did not have a complete transection? Did they need cyclophosphamide? So if they just got steroids, they had an EDSS change of 2.1. Steroids had a more robust effect for them than patients who were ASIA A. If they went to steroids and plasma exchange, that went up, almost double, to a 4.1. So there was a benefit from adding in plasma exchange to their regimen. Did we get even more benefit from adding in cyclophosphamide? And the answer is no, not a significant one. When you do the statistics and you compare the people who had steroids and plasma exchange versus any of the groups who had cyclophosphamide as part of their regimen, if you were not ASIA A, Cytoxan was not as helpful. The caveat to this is if you had an autoimmune disorder, an underlying autoimmune disorder, even if you weren't ASIA A, we think you should get Cytoxan. And it has to do with some of the statistics behind here. But if we just look at somebody coming into an emergency room, into a hospital, and distinguishing them as to whether or not they're ASIA A on the scale or not, it can help guide whether or not you should pull the trigger on the use of this chemotherapy or cyclophosphamide. Again, with all of the caveats that we've discussed. What about looking at this from the percent maximum improvement? Remember I said there were different baselines. How much better did we get people relative to their baseline? So in ASIA A group, just getting steroids, it was 3%. Plasma exchange, 17% of their expected recovery if we were to get them back to normal. Cyclophosphamide, 47, so approaching the 50% range. Whoops. And the combination, 145%. Now you can ask, how on earth can you get 145% of recovery? What it means is there was a patient who came in with an EDSS of about 3, who at their worst was an 8. They got Cytoxan, plasma exchange, and steroids, and when we were done with them, they were a 1. They went better than their original. Very unusual. That is not the norm. But that's where you get 145% from. And if you look at the non-ASIA A, steroids alone, about 40% of expected improvement. You get to 70% recovery if you use plasma exchange. And when you talk about adding cyclophosphamide, the number says 85% and then goes into the 70%. These are not statistically significant in terms of difference. So we did not see a benefit necessarily to adding in cyclophosphamide to patients who were not ASIA A on that scale. Does that make sense? Yeah.
You break down ASIA B and C and D all.
Not enough numbers to power it appropriately. It's a good question. So, yes?
What do you consider the acute stage? What's the time frame?
That's a great question. So we'll see patients' symptoms progress even up until 3 or 4 weeks. And so if somebody comes in and they're not ASIA A and they get steroids, but despite that they progress, they fit into that acute setting. Sometimes people's inflammation smolders for days or even weeks, and if you haven't knocked it out enough, you may have to go to something more robust.
Is this formula available to doctors such as...
So in 2 weeks the paper will be out, and if they decide to read it, it'll be up to them.
Does that go on the web?
And it'll be available when they release it. Yeah.
A lot of that information from John Hopkins.
It'll be out there, and
You're
Sure, absolutely. It'll be out there, and I'm sure we'll have it linked with the Transverse Myelitis Association page as well. So you saw this algorithm. I've made it very small because I'm not going to dwell on the details from Doug's talk. The idea of diagnosis classification. You present to the emergency department and you're having problems with sensation or motor. This is ideally what physicians are supposed to work through with you to try and decide if you are experiencing acute transverse myelitis. That's great in terms of diagnosis, but now we have to fill in the end. What do you do next? So it goes back to the idea of stroke. The public health campaign of stroke started when there was an intervention that made a difference. So one of the arguments we're trying to push in the transverse myelitis community is if we know about interventions that make a difference acutely, then people need to be aware, both patients and physicians, about getting in and getting accurately diagnosed. So someday what you might see is something like a spine attack. So we have heart attack, brain attack, and now we have spine attack in terms of getting physicians, internists, emergency room physicians, patients, public, aware of the signs and symptoms, because we think, have a lot more to offer in terms of limiting the amount of damage that patients will experience. So, the conclusions. Patients with transverse myelitis secondary to a systemic autoimmune disease seem to respond best to regimens that have cyclophosphamide. I didn't present all that data today, but we did talk about the folks who are Asia A. They definitely respond better if they responded better in our group if they had cyclophosphamide included. Patients who were not Asia A did not show that same response, but they did show a response to plasma exchange. So that sometimes it's not enough for the Asia B, C, D just to do steroids. There may be some clinical judgment, excuse me, to add in plasma exchange. And finally, they talk about in the stroke world, time is brain. In the cardiac world, time is heart. In the transverse myelitis world, time is cord. So if there's a delay of 4 weeks, that's 4 weeks we're missing in terms of intervening. So we're going to try and push the clock. So some thank yous to Project Restore, the Transverse Myelitis Association, the Cody Unser First Step Foundation, all of which came together to support this. These are some of the members of the Johns Hopkins Transverse Myelitis and Multiple Sclerosis Center. Let's see, this guy here, Douglas, this woman here, Chitra, I'm this guy here. To you guys, or patients and families who struggle in a not-so-friendly medical environment all the time to try and improve your care and the care for others. And ultimately, to my family, my wife and 2 girls, Rebecca and Hannah, who make it possible for me to be here today and do the things I enjoy.